Hello, everyone, and thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a quick few housekeeping items. The Private Practice Simple Solutions program is a series of rapid learning cycles designed to provide opportunities to implement actionable changes that can immediately increase efficiency. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to carefully review this notice. I'd like to now introduce today's speakers, Dr. Yun Boylston and Verna Little. Dr. Boylston, take it away.
Great. Thank you, Sumbul. And I just want to thank the AMA for the honor of inviting me today and any opportunity to collaborate with Verna, who is a true thought leader in this space, I will take. And so welcome. And today we are talking about integrated behavioral health in the private practice setting, which is near and dear to my heart. And we'll start off by the broad reaching goals, like what are the goals of integrated behavioral health and the opportunities for your practice. And hopefully this will really hit true for many of the things that you're trying to accomplish in your clinical care and running a busy and hopefully thriving practice. So the goals are many, including increasing patient access to care. You know, one of the pain points that all primary care providers have currently is there just aren't enough specialists in the psychiatric or psychological space to really refer all the patients you have who really would benefit from this care. And secondly, to really improve patient experience and satisfaction, you know, we really focus on making sure that patients identify your clinic or your practice as their true medical home and where they can receive whole person care. And so being able to offer BHI is such an integral part of the whole patient experience at your practice. And additionally, we want to improve patient outcomes. We want patients to achieve successful management of their conditions, to be able to reduce comorbidities or other complications that they have that stem from their behavioral health condition. And so certainly this is aligned with that effort. And then aligning with clinical standard of care, right? That as more practices and move towards providing this service in the primary care setting, that it really is becoming the clinical standard of care to offer these services. And then we really want to improve the provider and staff job satisfaction. We know that it can be incredibly frustrating to see this need and not be capable of meeting this need for your patients. And then lastly, as with all issues or topics in the private practice setting, it's really got to be directly related to achieving financial stability. And so we'll address that as well. And as you can see here, there are a lot of perceived barriers or maybe things that come to mind very quickly when we think about challenges in implementing behavioral health integration at your practice. And some of these may sound really familiar to you because they certainly do to me. And so really for a clinician, the first question is, how the heck am I supposed to do all this in 20 minutes, right? Or I really want to treat mental health, but I really dread my schedule blowing up and just having that happen in the afternoon and then you're toast for the rest of the day. But the reality is that establish BHI workflows within your practice with the use of warm handoffs or having skilled staff who can also help support this work can actually facilitate workflows and create efficiencies. Another perceived barrier is, I can't believe how long my patients are waiting for a behavioral health referral. The reality is that with integrated behavioral health services, you can actually address the majority of presentations of behavioral health conditions and or be a temporary bridge until your patients can eventually access specialty care. Another perceived barrier, I don't feel comfortable managing behavioral health conditions. And that was certainly true for my practice, myself and my colleagues. And really for the resourceful-minded practice, there are many quality and often free resources that exist for clinicians, regardless of what state you're in, that really can help you develop the skill set needed to be successful at behavioral health management. Another concern is I'm afraid to spend all this time doing all this work and not get paid for it. And so this is where some of the back office and being more astute with understanding how billing and coding work for behavioral health, and as well as workflows within your clinic, because these are the key to getting paid for the work that you are doing. Another concern, it's frustrating not to be able to help patients with what they need. And we all know that when it comes to behavioral health, moral injury is real in the clinical setting where you see so much demand and you feel somewhat incapacitated to really help. And the effort that you put in to try to meet your patients where they are, they will truly appreciate the care that you're able to give. And then lastly, the thought that my practice doesn't have the resources or staffing to do this. I argue that for private practice, we do this best. We are the ones who take nothing and make something. And so the key to behavioral health integration is to start with what you have. And we are truly the best at being resourceful. Next slide, please. And there is a wealth of a body of information that really shows us that behavioral health integration works. This is not a new or novel concept. It's been studied. The tires have been kicked for quite some time. And there actually is a lot of data that shows benefits, not just financially, but also of clinical outcomes. And so these are just a few of some of the evidence that's out there in terms of a decreasing total cost of care, provider satisfaction, as well as improved workflow efficiencies, and specifically within integrated behavioral health models. The collaborative care model has had lots of good studies that show evidence for targeted treatment and outcome-based care. Next slide, please. And next, I will turn it over to Verna.
Thank you so much. It's a pleasure to be here. And I absolutely couldn't agree more that the small practices are where you really find the creativity, because I think necessity builds creativity and builds what needs to happen. So really excited to be able to give some information. The good news is that there are more resources and options available now than there ever have been in the past. And when I think about small practices trying to figure out how to build in and integrate behavioral health, there's a couple of ways to think about it. So you can hire a full or part-time behavioral health provider, or you can share one with other practices in the community. So share in the hiring and the salary fringe and the overhead. I think this has a lot of good opportunities, especially now since there's some changes in some of the codes that some of these providers can use. It does mean that you have to credential them with your plans. You'll have to figure out how to bill for them and do a bit of a pro forma, but certainly the opportunity even to share is a little bit more viable now given some of the new codes. Also, I think a lot of times people feel like their patients need someone in person. The research doesn't actually support that for behavioral health. So it is possible to have someone work remotely and do some other kinds of visits, to do telehealth visits or video visits. This can actually work really well, particularly if you're in a rural area, or many of your patients would have barriers in terms of needing off-hour care or just for accessibility. And certainly it's better than not having a behavioral health partner. What I would say very clearly is really consider the type of licensure before you do that. The thing about behavioral health providers, and this is getting much better, but certain providers can bill certain codes and others cannot. Until very recently, counselors were not recognized by Medicare. That's actually changing now. But there are some commercial plans that aren't as generous with credentialing, particularly in rural areas, some different licensure. And so I would really think about the licensure, get some advice or information before you go forward and hire someone. I would also think about the populations that you want to care for first. If it's not possible to care for your entire, all of the patients that you see, do you have a particular population that might be the most helpful? So do you have someone, maybe a lots of pediatric population below the age of 10, and maybe you just try to figure out what you could do for that population, or seniors, or maybe people with depression and anxiety. So maybe think about what that might look like, and do a full pro forma. I get contacted by so many practices that weren't really expecting some of the problems they might have with billing, or how long it might take to credential. And so I really would encourage you to do a full pro forma, talk to your payers, figure out what the reimbursement is going to be, and then really be clear up front, like you would with any other provider, how many visits this person has to have in order to be viable. Right now, also more than ever before, there is an opportunity to contract out for behavioral health. And this looks really different now than it used to, given some of the changes in the codes. So certainly the telehealth codes, and you can contract with a telepsych organization or a telebehavioral health organization to be able to provide behavioral health services. And there are some that will directly embed in your practice, and others that you can contract with. We're going to talk about collaborative care, and you can contract for collaborative care. And so, an organization can come in and provide the behavioral health that's necessary to do collaborative care. I would say really vet the vendor. What's really important to you is, right, to quick turnaround in terms of referrals, very important. Are you going to want data around outcomes for some of the other initiatives or quality measures that you might be participating in? So really vet the vendor and really ask the kinds of questions. What kind of data, and how do you track data? How do you care for patients, and who's going to be caring for my patients? Are they licensed? Are they not licensed? What kinds of services are they going to be providing? Go ahead. And so you could also do a hybrid. You could build and maybe hire someone part-time and then contract out for collaborative care, or as an example. So there's a couple of things we know to really keep in mind when we think about optimizing integrated care. And there's a couple of things that we know really make that team successful and really make integration successful. The first is really thinking about shared care plans. So we're not going to have a behavioral health treatment plan, and we're not going to have, a primary care plan. We're going to come together and we're going to have a shared care plan. And this is something I would almost insist on right from the beginning. And shared care plans meet the requirements for a treatment plan for behavioral health, so you can come together. I would also think about some shared accountability. What quality measures are really important to your practice, maybe that have dollars attached to them, or that you've been working on that are important to you or important for other initiatives? And then everybody's accountable, so that if I come in and I'm a behavioral health provider in your practice, I also am very invested in trying to help you with the number of patients who get a flu shot or have a mammogram or any of the other quality measures, and that you may also work on some behavioral health measures, that you really have shared records. It's very hard. I talked to a vendor yesterday, and they were working with a practice, and it was so difficult because they were sending records, they were sending consult notes, and the practice couldn't find them. They were trying to find them and scan them in and attach to the visit. And it was just a really difficult process, and the providers weren't able to see the notes. So I would say really encourage you to share access to your electronic health record. And that way, oftentimes it's equivalent of like a medical assistant. Somebody often won't be prescribing or placing orders. And so it really is something that I would strongly consider, so that you have your documentation in one place, and that person feels like a team, and they can see your notes and you can see their notes, and that you really have some real understanding of what that person is going to do. How do they care for patients? What does that look like? And also that they have an understanding of what chronic illnesses you take care of and the patients that you see, so that there can really be a team and you can care for your patients and sort of optimize bringing someone in to do the behavioral health services, whether they're contracted or whether you hire someone or it's some version of a hybrid. And so when we think about some of the options for integration, certainly you can co-locate someone in. I would say for the most part that unless you're really thoughtful about this person being co-located and they're going to share your records, you're going to have some kind of shared accountability, that oftentimes this has someone come in. I've heard from so many practices and they bring a behavioral health provider in, and before you know it, that provider is full, and then they're kind of back where they started with there being a wait list. And so to really be thoughtful about what that looks like, how we're going to know people are getting better, what the caseload is going to look like, and how we're going to care for people. And really making sure that they're a transdisciplinary team member, that all those pieces are in place we talked about, whether they're employed or contracted. So I would strongly consider you to think about all of the options that you have and the kinds of integration. So one of them is the collaborative care model, which we'll talk about, an evidence-based model that Dr. Boston mentioned, has lots of studies and evidence to support it. Also thinking about primary care behavioral health, or the PCBH model. And now one of the things that's changing is the health and behavior codes can be provided by a variety of behavioral health professionals. This was not the case in the past. The regulations are likely changing in January. And so that means that for a lot of your anticipatory guidance, obesity, smoking, a lot of any behavioral health provider that you could bring in can now help you with those patients as well as take warm handoffs for some of the populations that you have. Also, maybe thinking about options for referrals. So there are a lot of organizations now that do a really nice job with specialty populations remotely that serve all of the states or most of the states. As an example, Charlie Health does adolescent up to age 33, like intensive day treatment, mental health services, take patients the same day, really nice, strong referral option. Or Equip for eating disorders, so that for some of your patients who might need specialty mental health, there's some additional options now. Or with a local provider, if you have someone that specializes, or make make an arrangement with you. I worked one time with a practice and the local community mental health center, and people that called the community mental health center that were either patients of the practice or who didn't have a primary care provider that were calling for care for depression and anxiety actually went to the primary care provider. And if patients that then needed specialty mental health in the primary care practice had more access in the community mental health center. So really coming together and thinking about arrangements like that are helpful. And then really thinking about your population so that you can really try to say, how many health and behavior needs do I have? Do I have patients that need specialty mental health? What about my broad primary care population? Maybe think about, where do I want to try to solve the problem first, and then go from there with what some of your options are. Go ahead.
Great. And next, we'll talk about the potential revenue and value to your practice, and recognizing that that the value certainly includes the financial value, but also the intangible value as well. And so some of the ways that integrated behavioral health services can increase your revenue is to really provide a consistently increased visit volume. You know, primary care is very seasonal. We rely on flu season, acute illnesses, but for behavioral health, you know, especially for management of chronic conditions, there is greater predictability in scheduling these types of visits than relying on sick urgent care visits. Secondly, there's payment for higher complexity of visits. So as we know, if you have evaluation and management codes, behavioral health by its very nature puts you into like the established 99214, 99215 categories. It certainly isn't just like a very focused, diagnosis of otitis media. And another potential revenue, capture opportunity is the optimized staff deployment with behavioral health integration in the context of telehealth visits. So for our clinic, one of the ways that we promote efficiency, especially when we're understaffed with nursing, doing is we tend to put in additional behavioral health telehealth visit blocks, recognizing that the provider is essentially a little bit on autopilot because it kind of removes the need for a very hands-on nurse during those visits, and they can be deployed to other needs, within the practice. There's also a fair bit of ancillary income. Now, no one is going to achieve ridiculous profitability off of surveys, but the time to administer and review and discuss surveys, these would be things like the PHQ-9, GAD-7, certainly many others that cumulatively, you might be really surprised by what that revenue stream means to your practice. And finally, the additional revenue streams with collaborative care model codes. The distinction with these codes, conventionally in primary care, the physician or the APP, they are the revenue centers, right? And so it's very much, I provide a visit, and this is my, this is what I bill. But the beauty of collaborative care is you have your behavioral health care managers who basically bill on behalf of the provider. And so it's essentially a novel revenue stream for your practice that you probably haven't had the opportunity to tap into. And then we move into kind of the intangibles that are so important for your practice. And ultimately, they do inform the bottom line, which we'll talk about. So it increases patient satisfaction and loyalty. With primary care, that's the value proposition for primary care. You come to me for whole person care, and I will continue to see you. We have a relationship, which is fundamentally different from an urgent care setting or more of the consumer type of, urgent care models out there that we, the reality is we compete with now, right? And as a part of that, it really improves the fidelity of your patients, to your practice, that they will continue to stay with you, they will have longevity with you, and that's deeply gratifying, not just for the relationship and the trust between patient and provider, but also in continuing to build a healthy patient panel for your practice. For me, and certainly for others, you'll find that, improved provider satisfaction and retention. We've all seen the AMA publications now talking about how many primary care providers, many fields, including pediatrics, is greater than 50% burnout. We all believe it because we live it. And so really being adept at delivering integrated behavioral health for me has been, a tremendous source of just really improving my connection to my patients, feeling empowered, like I can do something to help. And I think ultimately it's really good for longevity for all of our clinicians out there. It certainly improves quality of care as well as outcomes. If we'll go back to the last slide, please. And that's really important for all of us who increasingly are in value-based care payment models. We might be a part of ACOs. And so these are all the metrics that are being looked at a higher level, for our practices. And then lastly, the potential to decrease total cost of care while increasing or improving outcomes is certainly the gold standard for all of us. So the next slide, I will turn it over to Verna.
We've talked a little bit about collaborative care, and I think it's helpful to just do a little bit of a deep dive. So collaborative care is an evidence-based model that was dedicated in 2017 with some CPT codes specific to the model. And essentially, collaborative care is evidence-based for depression and anxiety in healthcare settings. It is very different, as we sort of alluded to. It is a monthly case rate. So that means the total number of minutes spent caring for a patient or in patient-related activities every month is billable. They are technically referred to as incident to codes because they can only be billed by primary care providers, but actually they kind of fall out of some of the incident to requirements, like the provider has to be on site and some of the others. So they are adding 2 people to that primary care team. The first is a behavioral health care manager. CMS says that this person does not have to be licensed, but they do have to provide all of the treatment choices in collaborative care, one of which is talk treatment. So the nice thing is that it is very measurement based, using the PHQ-9 for depression, the GAD-7 for anxiety, and really looking for that 10-point or 50% reduction in the first couple of months. The average amount of time in collaborative care is about 6 to 8 months. And that behavioral health care manager really manages patients with the primary care, pediatric, women's health provider, really helping to reduce those scores, sometimes talking to them every day or every other day, setting goals, following up. And if someone isn't getting better, they meet with the second person that gets added to the team, the psychiatric consultant. And in collaborative care, the psychiatric consultant doesn't see patients or prescribe meds. They meet with that care manager weekly, talk about those patients that aren't improving, are having side effects, and then make recommendations in the electronic health record to that healthcare provider. And so it really allows for access to service because it can be same day, next day. It is by nature a remote option. Telephonic actually works best for those frequent high touch patients. And also it becomes very affordable because it is a monthly case rate and because it falls under primary care. So the idea is that my copay for going to see the provider might be $20, and then I'm paying $20 for a month of collaborative care. So it becomes accessible and affordable, particularly for your commercial and your Medicare patients. So this is a little bit about what it looks like in practice. This is from my organization, Concert. We do contract out. And so, but this is a really nice example. This is what the primary care is responsible for. They're still captain of the ship, I like to say. They really establish the diagnosis. They might do the screening. And I think it is important to add the screening to your practice. That 96127 code, you know, it adds up over time, the G code for Medicare, but it adds up over time, and some payers will pay it multiple times a month. So really good. And then you also can track how many screenings you've done. They do a warm handoff. Oftentimes this person is telephonic or remote, and that's really helpful because it can be, hey, I work with Verna. She helps me care for my patients who are sad. I'm going to have her give you a call later today. And that makes a big difference because then I'm doing this warm handoff to the behavioral health care manager, to that clinician who's going to manage me, and then talk to the psychiatric consultant if I'm not getting better. And that psychiatric consultant is going to help with any diagnostic questions, any patients with comorbidities there might be difficult, and make recommendations for labs, for medications, whatever is most appropriate for that patient in collaborative care. So collaborative care now is on the Medicaid fee schedule in about half of the states. We still have half to go. So it provides a really nice option, whether you build it or contract it, to be able to have a behavioral health provider, access to a behavioral health provider that might be able to help you care for a pretty broad swath of your patients. And again, more than half of the states, Medicare Advantage. So certainly Medicare Advantage, Medicare, and all of the commercial plans. We have actually not had a commercial plan that is not reimbursing for collaborative care. So when we talk, go ahead, Dr. Burlstein, go for it.
Oh, thank you, Verna. And so, Verna provided just a really helpful snapshot of one archetype of integrated behavioral health. And so this is another case just to highlight primary care behavioral health model. And just so you know, this is a choose your own adventure when it comes to particularly private practices, that your model, what works for you may actually be a hybrid of maybe the collaborative care and the PCBH model. You may decide to take initial steps to work towards maybe one of these, but there are certainly other models, and we just wanted to highlight maybe two of the more commonly used ones. And so for PCBH, It also follows the same tenets of integrated behavioral health that Verna so nicely outlined for collaborative care. I just love that she used the term, the behavioral health provider is such an integral part of the team, the primary care team, and that is really the foundation for a successful integrated behavioral health model. And so this is very much, again, like collaborative care. PCBH is it's a team-based approach to supporting behavioral health care in the primary care setting. And the PCBH model includes a behavioral health consultant. Commonly, this might be a master's level psychologist or a PhD. And they are commonly a part of team huddles, warm handoffs with the primary care team, and really part of the daily workflow. And so the distinction is they're not a specialist that you call or selectively use. This is a service and a team member who really is available to the majority of your primary care patient panel. This individual can be virtual or in person. I think Verna really captured that well, that in this day and age with all the digital advancements, there are so many things that you can bring into your office, and it helps us overcome some of those geographic constraints. And the key here with PCBH is focused intervention, because one pitfall is you don't want the behavioral health consultant to be consumed and bogged down with just 5% of your patient panel who are highly complex. This is truly for the individuals who just need focused support, behavioral activation, or like a defined series of sessions where after which they're moved on and transitioned to a community therapist or other behavioral health provider available in the community. And again, they're broadly available to the majority of the practice's patient panel. A key distinction, and this is true for collaborative care as well, but for both of these models, the behavioral health expert who is embedded in your team really strives to educate the team as a whole, whether it's your staff, other clinicians, the primary care providers, to upskill all members to be knowledgeable, to be comfortable in having these discussions, as well as, tips on management. And so I think that's how we really share best practices and lift up the whole team to do this work. And keeping in mind that with the PCBH model, because these are behavioral health consultants, oftentimes in the like psychology expertise realm, that there are specific CPT codes that primary care typically does not use. And so if you are interested in pursuing this model, then you really want to make sure that these CPT codes are included, and you understand the rates in your current insurance contracts. And it's really promising that Verna mentioned, because of the need for this behavioral health support, that a lot of the restrictions on these codes are being liberalized. And so the key takeaways today, because this is all about fast action, see what we can do today within the constraints and the resources that you currently have. And so the first would be assess where your practice is now. Can you find ways to measure the current unmet demand for behavioral health integration services at your practice? You may want to track, length of time between referral to eventual first appointment for your patients. That might be really eye-opening to really make the argument to the stakeholders within your practice about maybe your need and your patient-specific needs in approaching your work on behavioral health. Secondly, brainstorm how to build on what you're already doing. Odds are really good that either functionally or just in a practical sense, we know that you're already doing a lot of this work. And so, you can find ways that, well, what do we do well currently? And how do we increase capacity to better meet demand as well as to increase revenue? And then another good assessment tool is quantify your current behavioral health revenue. So what is your current revenue from behavioral health? This might be doing a report from your EHR or your billing system about visits with primary diagnosis of behavioral health conditions like anxiety or depression. There are different ways you can go about that, but I think you might be surprised that it really does constitute a significant part of your current revenue stream. And then, certainly survey your providers to assess their comfort level in managing behavioral health conditions. So your primary care team, collectively between your clinicians, whether they be physicians or APPs, certainly for our practice, we recognize and honor that everyone is on a continuum of comfort. And so it's really about helping to support everybody, not developing, these are the people who do behavioral health at our practice. Ideally, that you provide a fairly consistent standard of care for your patients, regardless of who they may see in your setting. And then lastly, examine your current behavioral health workflows. What changes could be implemented to improve screening rates, increase your appointment availability for a behavioral health visit, and to raise revenue. So some of this might be, working on the workflow for surveys, right? So if you don't currently have universal surveys for PHQ-9s or GAD-7s to evaluate for anxiety, what are some ways that we could change the workflow, or at what point during the appointment experience do the patients receive this information so that they can be evaluated or reviewed during the time of visit. And so those are all things that are going to require multiple stakeholders and all members of your team, whether it be, and certainly actually these are the most important people, everyone from the receptionist who greets the patients to the people scheduling the appointments, to your clinical team, and certainly to your provider team. All right. And thank you so much. Gosh, I guess, time flies when we're having fun. And certainly that was the case today. Verna, it was such a pleasure to be here with you. And Sumbul and AMA, thank you again for the opportunity to share in this discussion. And we look forward to seeing everyone during our office hours where we can continue the discussion, and we look forward to engaging with you.
Absolutely. I'm really excited to see all the questions in the chat and be able to follow up with everyone. So I look forward to seeing you there. And thank you, Dr. Boylston. It's always a pleasure.
All right, that concludes our presentation for today. Thank you to both our speakers for sharing their time. As they mentioned, please go ahead and check out that attendee chat. It'll be on the left-hand side of this webinar, and we encourage you to check out additional resources on the Steps Forward website. Thank you, everyone. Have a great day.